Good morning, everyone. Thank you very much again for the introduction and for the invitation. And what I'm gonna have been asked to talk about is the safety of the ABT 450 regimens. And I think safety is absolutely crucially important. And I showed this slide several times, also 2 days ago in the evening session, because safety will enable us to increase the number of treatable patients if we have regimens that are easier to treat. We discussed it frequently that interferon-free therapy will change to this, will change the treatment paradigm, and hopefully we will increase the number of patients treatable. Again, I showed this before, but I think it's the important message. Currently, we could only cure a small proportion of patients diagnosed with hepatitis C, but certainly with interferon-free therapy, we could increase this, and by this, we can also increase awareness and then should be able to cure more patients. But this entire concept depends on the fact that the new therapies are really safe. So safety, I think, is absolutely crucial, and therefore we really have to keep an eye into the details of the studies that have been published in the last 12 to 18 months. Are there maybe some tiny hidden safety issues which may then cause greater problems in real-world settings? And again, we discussed this several times during the meeting, that the number of estimated infections can decline in various countries if we increase not only efficacy, but also access to therapy. This is the blue line, and this is, again, only possible if the new therapies are really safe, and this is the figure for Brazil that has also been shown on Wednesday already. You would be able to almost eliminate HCV in this country if you increase the number of patients treated until the year 2030, which I think is remarkable. So let's have a closer look to the safety issues of the new regimens. And just to the last introductory remark, I think the concept of eradication a disease by treatment is absolutely new and novel. This has never been attempted before. We have been able to eradicate and to control diseases, infections by prevention, but to eradicate something by treatment is unique. And theoretically, we will have the tools. It will be on us really to bring this in real life. So safety is important, and I don't want to talk about the first generation PIs in more detail, just to remind all of us that it was challenging to use these new PIs. We were successful. If we selected patients well, we could cure many patients. But it was not possible in every patient, and some patients were really put at an increased risk, and some patients even died, and therefore, again, safety is important. So you have heard just the data of the AbbVie regimens, the phase 2 trials. The phase 3 trials have been published in the New England Journal of Medicine and in Gastroenterology in the last 8 to 12 weeks. And if you summarize all these studies and data, I think it was remarkable that depending on the subgroups, between 82 and 100% were cured. The far majority of SVR results were 95, 96%. There may be some subgroups where it would be slightly lower. And to all of us, it was a big surprise that the numbers were that high. This was the case even in patients with cirrhosis, who may be at higher risk also for side effects. However, it was remarkable to read that there were almost no side effects. So what is the safety profile of these regimens? And this number is just by coincidence if you get reminded to something else. I want to apologize for that one. And let's just go through these 7 points for AbbVie. Okay, so we have various interferon-containing regimens, and what we want to achieve for is the interferon-free regimen, and the AbbVie combinations are completely interferon-free, which is basically the first goal. And I think this is a major step forward. We all agree to get rid of interferon. So we are not anymore talking about interferon, which will enable us to treat many more patients. These dia combinations, Rafael Esteban introduced to you already which targets are. It's very important to remind ourselves that we are talking about a combination with a protease inhibitor, an NS5A inhibitor, and a non-nucleoside polymerase inhibitor. You know that in future we will basically differentiate between nuc-based and nuc-free regimens, and this is the regimen we are talking about: non-nuc, protease inhibitor, and NS5A inhibitors, which is not unique to the field. There are also other programs basically exploring these triple combination. So the second point then certainly is we have seen many data. Many data have been published in the New England Journal of Medicine, and frequently pivotal trials are criticized that patients are very well selected and that they do not present real-world cohorts, and that even though you see wonderful results in a New England Journal of Medicine paper, if you then use these compounds in your own clinic, that you have some problems. But I think the second goal here is really that these phase 3 data that we have seen in recent months really included many ill patients and patients with advanced fibrosis and also older patients. And we have to highlight, for example, for the study in patients with liver cirrhosis, that the inclusion criteria were even wider than we have been used for interferon-containing trials. Interferon inclusion criteria meant lower platelet count level of 90,000 in the phase 3 trials. In this trial, for example, in the Turquoise trial, the cutoff was 60,000. So patients were more advanced than patients that we have treated in previous trials. And just to go to these 3 pivotal trials which were published in the New England Journal of Medicine, the SAPPHIRE-1, to remind you, is a trial in treatment-naive patients. And you can see here that these patients were on average 52 years old. Some of them were overweight. This is also interesting to note for those of us who are in the field for quite some time. Every 10 years, with new waves of drugs, patients also became 10 years older. And Raphael, the first New England Journal of Medicine papers was ribavirin interferon. I think the average age was 38 or so. Now we are talking about 52 years of age. And the SAPPHIRE-2 trial were patients, non-cirrhotic, who have previously been treated already with an interferon-containing regimen. And there you can see they are even 2 years older. We are talking now about 54 to 56 years of age. And the third trial, also published in the New England Journal of Medicine, was the Turquoise trial, which included both treatment-naive and treatment-experienced patients with liver cirrhosis. And there you can see now we are talking about a mean age of 57 years. And also these patients, let's say, had a higher BMI than those in the treatment-naive trial, which is reflected most likely by these 5 years age difference. So I think this really represents a real-world cohort. Many of our patients that we see outside are reflected in these trials. Also consider this cirrhotic trial. You see here the platelet counts. There was a significant proportion of patients, 1 out of 5, who had platelet counts below 100,000, and 12% even had serum albumin levels below 35 or 3.5, depending on the unit. So I think this is really one strong point for this trial. So what were then the frequency of adverse events? And this is the third goal. Only a minority of patients really had higher incidences of adverse events, and these adverse events were mainly driven by ribavirin. So let's go again through these 3 trials. You can see here in the safety issues that there were more frequent AEs in this SAPPHIRE-1 study, and this were mainly nausea, pruritus, insomnia, diarrhea, asthenia. Many of those can be attributed to ribavirin. This was in the treatment-naive trial. In the treatment experience trial, the differences here you see were less obvious. These patients went already through an interferon-containing regimen, so there's a selection of patients who may tolerate something. But again, pruritus was more frequent in the patients receiving the 3D combination plus ribavirin, but also for the other ones you see numerically differences, which however did not show up as significant. Maybe most important, these were patients without liver cirrhosis. What's about adverse events in patients with liver cirrhosis? This is our problem. And liver cirrhotic patients are at higher risk of experiencing side effects. And again, you can see fatigue was slightly more frequent, but none of them was different as was really showing up at a very high frequency. Keep in mind the Turquoise 2 study had not a control arm, an untreated control arm. This was comparing 12 versus 24 weeks, but again, frequencies of adverse events that were lower than in all previous interference-free therapies. These were adverse events, and in these papers you can read the number of adverse events, of events that occurred at least in 10% of the patients. But what really matters in real life are serious adverse events, so where patients are at risk of even of dying. So, and I think this is, again, the next goal. It's the fourth goal. They were very rare. And for those of us who took part in this trial, it was remarkable to see how well these drugs were tolerated. Some of our patients even accused us that we were giving them placebo. They didn't believe that they were actually taking the active medications. So in the respective trials, you can see here that only 2% in the Sapphire-1 trial experienced serious adverse events. And you can see here that 2 of these 10 were possibly related to the 3D regimen. And in the Sapphire-2 trial, it was 6 patients, so also 2% who experienced a serious adverse events. And there was no specific pattern noted in these serious events. One event was considered possibly related to the drug regimen, and this was an ischemic attack in a patient with risk factors for hypertension, age, etc. So this is something certainly where we still have to keep an eye on these patients if we give ribavirin, which may be risk for some patients when we select our patients for future treatment regimens. Again, this is the data for the patients with liver cirrhosis, and here you can see that the frequency of severe adverse events was 6.7%. Here we're talking about those patients with very advanced liver disease, 60, 70, 80,000 platelets, but hepatic decompensation was observed only in 4 patients, and none of them was considered to be related to the study drug by the respective investigators. So we have a low frequency of adverse events. We have a very low frequency of serious adverse events, but were there cases where patients had to stop drugs because of adverse events? And I think this is really serious. You may consider, even if the overall frequency is low, but if patients stop very early during treatment because of adverse events, this may still be representing a problem for the future selection of regimens. And this is the 5th goal. It's only in single cases that this actually occurs. You can see here the respective figures for the non-cirrhotic trials. Only 3 patients in the Sapphire-1 study discontinued the study drugs due to AEs, and in the Sapphire-2 trial it was again only 3 patients, and the reasons are listed here: pneumonia, acute respiratory failure, and the third one was abdominal pain. And here 1 patient had ALT elevations, 1 diarrhea, and 1 patient's acute renal failure. So this is considering a large number of patients, really a very low number of stopping treatment drugs due to AEs. You can see here again also the data for the Sapphire-2 that this actually occurred in 4 patients. I will skip this one. So what's about lab abnormalities during therapy? We are talking about liver disease. Sometimes drugs may cause drug-induced liver disease. We are talking about hepatitis flares and hepatitis B. You may see flares during treatment. And Actually, it was until 2-3 years ago unknown to what extent interferon-free suppression of viral load may also cause some increases in lab abnormalities. This is, to me, the sixth goal, because there was, and this is very, very important, there was no case where really signs of drug toxicity, of worsening were associated with the respective drugs. And this is High's law. If you have increase of ALT levels in parallel with bilirubin, this is a concern. This led to stop of development of various drugs, but this did not occur. Overall, you can see here that very few patients in the SAPPHIRE-1 trial experienced an increase in ALT levels. Only 4 patients, 5 times above the upper limit of normal. And you can see here that only 2% of the patients actually had an increase in bilirubin levels. So very low numbers, and very importantly, these 2 events did not occur in the same context. This is the figures for the SAPPHIRE-2, pretty much the same, 1.7% ALT increases, 1% AST increases, and only 2.4% of bilirubin increases. Again, these were the patients who had no cirrhosis. What's about patients with cirrhosis? And here, I think this is very important news, that we have ALT increases above the limit, 5 times above the limit of normal, only in 2.9%. Bilirubin increases were more frequent. This occurred in more than 10%, which, however, is not a big surprise. We're talking about patients with slightly impaired liver function, and we also expose patients to ribavirin, and this may cause hemolysis, and this explains to a large extent this increase in bilirubin levels. Again, none of them occurred together, so ALT was not paralleled by increases in bilirubin. And then the next question is obviously, what's about ritonavir? The protease inhibitor ABT450 is boosted by ritonavir, and certainly is this an issue in terms of drug-drug interactions? Can we manage this one? We talked a lot about this when using tenofovir, when using boceprevir. There was an issue in the transplant setting. Is this a concern? And to me, maybe one of the most interesting studies presented at EASL this year in London was that this is possible, and this to me is the 7th goal. The 3-D regimen was very safe even in patients with liver transplantation who received cyclosporin or tacrolimus. And the calcineurin inhibitor levels were altered, but this could be adapted easily. And I think this is very strong data, because frequently people said, oh, you have to combine 3 drugs, and the ritonavir is the 4th drug, and ribavirin is the 5th drug, and how does it look in really complicated patients? This trial is important, and Paul Kuo presented this, showing very nicely that this is possible. You can see here the frequency of adverse events, which was obviously higher than in the other trials, but we're talking about a transplant population. But what is very important, again, even in these patients, only 1 patient discontinued the drug due to AEs, and 2 patients had serious AEs, and none of them could be directly related to the study drugs. In transplanted patients, also lab abnormalities were very low. Only 2 patients had slightly increases in bilirubin levels. You can see here the hemoglobin issue, which certainly with ribavirin is something where we have to keep an eye on. But only 1 patient had hemoglobin levels below 8, so a grade 3. 5 of the patients received erythropoietin. I think very interesting data. And however, in the transplant setting, certainly we have to adapt the ribavirin doses accordingly, and this has been performed in this trial. What's about now this drug-drug interactions, ritonavir boosting with cyclosporin or tacrolimus? Here you can see the respective trough levels for tacrolimus. They were comparable pre-treatment and on treatment, and the TAC dose had to be adapted. You can see it was 0.5 to 1 milligram at 1 to 2 weeks intervals, and I think it really shows you have to keep an eye on that, but it's in the end easily possible, and this is a similar data for cyclosporin containing immunosuppression. Here the cyclosporin levels were maintained within the desired range in all of the 5 patients, and the dose had to be adapted only in 1 out of 5 patients. So The last point, ribavirin will be still part of the regimen, at least for some subgroups. It's likely that for genotype 1a patients, we will use ribavirin with the ABV3D regimen. And this is the one goal against this one. Because I think ribavirin, and this is what I learned also over the last 6-7 months using interferon-free therapies, that ribavirin is a nasty drug. And if we can avoid it, it's better. This is my lesson in particular in patients with advanced liver disease. However, in the respective trials published in the New England Journal of Medicine, the overall frequency of hemoglobin abnormalities was very low. You can see here the numbers for the SAPPHIRE-2 trial. And what is very important, that we really can track back the side effects to ribavirin. And this is published by Peter Ferenczi in the PEARLS trials, where the ABV3D regimen was compared with and without ribavirin. And in this paper, we have either genotype 1a and 1b, and you can see here some of the p-values. It's maybe hard to read, but again, all the AEs that are listed in the very beginning to be more frequently present with the 3D regimen can be related mostly to ribavirin. It is pruritus, it is nausea, it is insomnia. Those were significant, and indeed, this was more frequent in ribavirin-containing regimens as compared to ribavirin-free 3D combination here. So ribavirin causes some of these side effects. Most patients can take it. It may be an issue in more advanced patients, and I think in future also, when you will next year use the 3D regimen, if you can avoid ribavirin, for example, in non-cirrhotic 1b patients, we should not give ribavirin. This is the clear message. In the Turquoise-2 trial, again, the trial with liver cirrhosis, you can see here also that the frequency of these hemoglobin levels was slightly higher than lower levels than in the non-cirrhotic patients. But there was a poster which was presented last week at the International AIDS Conference in Melbourne by Mark Sulkowski, showing the kinetics of these grade 1, 2, 3 ALT hemoglobin declines, and this is basically the purple one is the grade 2 plus. This was paralleled by an increase in reticulocyte counts. So really the host is responding to this anemia, is trying to cover this, and importantly, this is also completely reversible after stopping the regimens. So ribavirin is the one goal against the regimen, but we will not use it in every patient, and in the end, it's manageable. Very importantly, anemia had no negative impact on SVR, which I think is also an important message for these trials. So very lastly, if we then want to use these drugs in real life, if we use them and if we want to avoid side effects, then we can save lives. Initially, I showed you these curves for the incidence and prevalence of infections. This is the slide on liver-related deaths for Germany, England, France, and Spain. And this is a number and the graph that we showed 2 days ago in this meeting. I think it's very important that we use these drugs in a responsible way. If we use them, we really save lives. Thank you very much.